Hello, everyone, and welcome to tonight's webinar entitled Step into the Right Footing, Understanding Charcot Foot, brought to you by Capital Health Network, together with the Australian Podiatry Association and the Walking Clinic. First, I would like to acknowledge the Ngunnawal people as the traditional custodians of the land on which we meet today and pay our respects to the elders past, present, and emerging. I also extend that respect to any First Nations people who are joining us today. Now, my name is Sheila Brito, and I'm the Allied Health Engagement Officer at Capital Health Network. Also with me tonight are the Education Lead at CHN, Kunal Mohite, and podiatrists Ricky Lee and Jason Bitar. But just a few things before we start. There will be an opportunity to ask your questions after the presentation has finished. Now, please type all your questions and comments into the Q&A section, not the chat box of the side panel of your Zoom window. Now, regarding CPD, please fill in the post-event evaluation survey. CHN will then email you a certificate of attendance after the event. Please feel free to self-report up to 1.5 hours of educational activities to your CPD home. Now, as a reminder, the Health Pathways website has guidelines and advice on referral pathways for urgent diabetes care, podiatry, and high-risk podiatry referrals. If you do not have personal login details, you may use the login together, which is the username, and the password is for health, FOR health, as one word. And now over to our presentation. So as I mentioned earlier, we have two speakers this evening, Jason Bitar and Ricky Lee, are both podiatrists from the Walking Clinic, which was Canberra's first podiatry clinic established by Ricky's father more than 45 years ago. Now, both Ricky and Jason are part of this growing team, and they are dedicated to patients' lower limb health and the prevention of high-risk complications. Now, they work closely with the ACT Health and the high-risk foot team at Canberra Hospital to manage concerns such as Charcot Foot, neuroarthropathy. So now I'm handing you over to Ricky and Jason to discuss this area.
Awesome. Thank you so much for having us tonight, Sheila. And obviously, thank you to the Capital Health Network and the APOD for organising this great event. So yeah, as said, my name's Ricky and this is Jason. And yeah, we're going to give a talk tonight. So the first thing we wanted to obviously go through was that we are podiatrists. We work in this area quite a lot, the Charcot neuroarthropathy, but it is also a multidisciplinary approach that works with this team. So as private podiatrists, we refer our patients into the high-risk team, and then that high-risk, that multidisciplinary team of orthopedic surgeons, vascular surgeons, podiatrists alike, all work really closely together to manage this condition and prevent. Yeah, so we'll just go to our next slide. Oh, now we jumped to. Beautiful. There we go. So first of all, we wanted to, so Charcot neuroarthropathy can be commonly sort of confused with another condition called Charcot-Marie-Tooth, which is a neurological condition that basically is a hereditary neurological condition that can affect the feet as well. But this is a very different condition which most commonly affects people with diabetes, but it also mainly is with neuropathy. So it's an inflammatory process that affects the bones and joints and the soft tissue, and often occurs in an individual with neuropathy. It's a rapidly progressive and non-infectious degenerative arthritis, excuse me, that's a mouthful, affecting single or multiple joints. Patients usually have a good blood flow with this. So it's generally not affected by blood flow, but it is also always associated with that neuropathy. So yeah, as said, common things that we see with this are less common ones, but your syphilis, leprosy, obviously we don't see a lot of that. But the most common ones are diabetes mellitus and your chronic alcoholism. Sorry, can't speak. With this one, it's relatively uncommon, but it's a very important one, obviously, to pick up with any of these things. So the International Diabetes Foundation estimates that 537 million adults lived with diabetes in 2021. The prevalence of this is 0.3%. So approximately 1.6 million people worldwide. We looked at the recent figures of Australia and how many people living in Australia with diabetes mellitus. And it worked out to be about 4,000 roughly Charcot foot cases would be known in Australia. So relatively small when it comes to those sort of things, but obviously a very important one. Now, a lot of that is because these people live with neuropathy as well. A lot of these cases aren't always picked up. People don't present when they've got active Charcot foot. And so a lot of these cases aren't picked up. That's probably why those numbers are quite small. And often these people present later to hospitals after they've had issues from their foot related to the Charcot.
So just a bit of a chat about the probable pathogenesis of this condition. So it's not entirely known as to why Charcot does occur. However, there are two theories as to why it may occur. The first one is our neurotraumatic theory. So Charcot neuropathy is caused by unrecognized microtrauma and obviously due to the sensory neuropathy, as Ricky touched on. So patients with diabetic neuropathy can't feel pain, so there's an uneven distribution of forces and uneven distribution of weight that occurs in the feet. That repeated joint stress causes undetected injuries, and over time it results in bone fractures and joint dislocations, and ultimately progressive destruction of the joints in the foot. Our other theory is our neurovascular theory. So autonomic neuropathy causes an impairment and causes a dysregulation to the blood flow, leading to increased vascular dilation and hyperemia to the affected joints. So this contributes highly to the bone resorption and failure to heal, resulting in joint deformity and rapid degeneration. So it's likely that both theories work together. So we get a touch of the neurotraumatic injuries, which initiates the damage, while the neurovascular changes accelerate the destruction. So because they're getting that healthy blood flow coming down to that area, it actually progresses that condition.
All right. So this sort of just puts what Jason was talking to in a sort of nice format. So effectively that we've got both sides there. So either neuropathic condition can cause issues. So long-standing diabetes or other neuropathic diseases leads to that neuropathy. That then includes that ligamentous laxity or joint instability. Now that can be from different causes, as that repetitive injury or osteopenia, but that repetitive stress that happens to the foot. So a lot of people might report they've recently increased walking or they've recently increased their activity, which can lead to that microfracture. There is also the possibility that they have their foot stepped on or they've kicked something. That can also lead to that. So it's really that unknown cause, I guess, is generally what happens because of the neuropathy. That then obviously leads to that joint instability. They're continuing to walk on it. So that painless ambulation is the main thing. They're basically continuing to load on these joints because they're unaware that those fractures or those issues are there. That obviously leads to, as Jason was talking about, that hyperemic response. The blood flow's shooting there. They're going to increase vascularity to try and heal these injuries. Repetitive trauma is happening, more bones getting laid down. That then leads to that joint degeneration and subluxation. Now, basically, yeah, that flows onto, we can quite commonly see ulceration or infection associated with this. And then we get that acute Charcot foot that occurs again, and then that continued weight bearing. So basically this bottom cycle, if patients don't present and get management, just continues and continues to get worse.
So other elements to sort of touch on as well, quite similar to what Ricky was saying, you get this, you get four sort of factors that come into this. You have your sensory motor neuropathy, so that loss of protective sensation where the patient's not actually feeling the damage happening to them. They get one of the key features that we do see in our very early loss of neurological status is that diminished vibration sensation. We have that muscle weakness as well as an ankle equinus. We couple that with autonomic neuropathy. So we see that AV shunting, we have that hyperemia, which we touched on as well. We then have the minor trauma, which is the repetitive stress on the joints, repetitive loading, and we get those trabecular fractures, and also previous surgeries can actually cause something like Charcot to activate if they do have something like neuropathy. Couple that with our other factors, metabolic abnormalities, that weakens the bones. We have, as we touched on, our diabetes, renal transplant, and immunosuppression. We put this Venn diagram all together, and it sort of gives us that perfect sort of concoction for a Charcot foot.
So the main things that we're looking for in diagnosis are a temperature difference. So generally the foot will present quite red and hot. And so you're looking for a temperature difference between both limbs of 2.2 degrees. So this is probably isolating, but most commonplace is the midfoot of the foot that we see Charcot occur. So you will see that sort of that midfoot will be very hot. So always comparing to the contralateral limb. So obviously the one that's not affected should be a standard. Obviously, if you've got two, both feet are reactive at the same time, which is less common, then you have to be suspicious of that. But yes, that will be the main thing that we see is that increase in temperature of that one limb. Obviously, edema is a big one. So this will be quite swollen because of that reactive state that the Charcot is in. There is a lot of increase in blood flow and inflammation of the area. Visual inspection. So the redness, swelling, erythema, they'll all be present. The pain is the big one. If obviously most of these patients will be neuropathic, so they won't have any sensation. So you will be checking to see if it is painful, then it may not be a Charcot, and so you may be looking away from that. So that will be something. Don't get me wrong, people can have Charcot with pain, but it's obviously less common because they generally don't get to that case where the bones are degenerating because it's pretty painful. They generally will present at hospital if they break their foot. Yeah, and then imaging is probably our biggest thing. I think we touch on that a little bit more. But yeah, certainly referral for imaging is your gold standard. So really with these ones, you have to try and exclude it if you are presenting with these sort of symptoms. So this is one other thing that will obviously be touched on, which is blood tests. There isn't actually a lot you can find in a blood test. So there's basically insufficient accuracy when diagnosing an active Charcot through inflammatory markers in blood work. They will be inflamed, but it doesn't give you a lot of diagnostic information. So your best bet is definitely your clinical judgment and radiology. Awesome. So this breaks it down a little bit further again. So this is sort of your cascade of if you are suspecting a Charcot foot. So obviously, first point of call if you've suspected, if you've picked up some of those other markers, temperature difference, the swelling, the inflammation seen around that area, radiology. So going for an X-ray is the first point of call. If you can see osseous changes on the X-ray, and they're positive for Charcot, then we're treating the Charcot. People obviously may go on to that next case. So if it comes back negative on an X-ray, the second line of choice or first line of choice after that is an MRI. If that again doesn't come up negative, you still can't exclude, comes up negative, you still can't exclude that it could be Charcot. So you're then going on to your CTs or spec CTs to further rule that out. So it is a little bit of one of those cases where we have to rule it out, and we can't be proven until we sort of really know it's not there. But yeah, you sort of end up at a CT scan as your final point of call.
So what might typically present when a patient comes and sees you? So we sort of see in acute Charcot foot, we see, as Ricky touched on, it's usually happening to one side. Very rarely do we see it bilaterally, but there are acute changes that we do look for, which is that sort of that swollen and warm midfoot. So we sometimes see a deformity, and it's what we refer to as that rocker bottom deformity, and that's just happening because the joints in the midfoot have collapsed. in our more chronic cases of Charcot Foot, they tend to be less swollen and less red, but the deformity is much more apparent. But the deformity becomes a huge issue because there's a now maldistribution of the pressure, which then can lead to midfoot ulceration. So our neuropathic ulcers can then occur with someone who has chronic Charcot Foot. They do get broken down into stages, and this just gives us a little bit of a healthy summary of the stages that we see. Just looking at that table below, in your sort of very early stage 0, we tend to only see sort of localized heat and swelling in that medial column along that sort of midfoot. Furthermore to that, when we get our imaging, we tend to see the localized osteopenia, subchondral cysts, and erosions. As the disease sort of progresses, we then see our joint subluxations, and this is where we would hope that we have caught it a little bit more earlier, because when these joint subluxations and dislocations, collapses occur, it's sort of irreversible unless they're going down path of something like surgery, which we'll touch on later, which isn't really going to be recommended. However, when it does get to its final stage on stage 4, we do tend to see that healing stage with the sclerosis and the fusion. So it's collapsed, it's deformed, but now the bone is remodeling into keeping it in that sort of form.
Awesome. So now we'll touch on some differential diagnosis, because this is probably one of the main things. This can be why there are probably so few cases sort of managed. Because there is that not misdiagnosis, but it can be a differential diagnosis. So a lot of the times, obviously, with the red heat swelling, infection or cellulitis is quite a common sort of diagnosis. Your gout, obviously, that inflammatory red, hot swelling sort of arthropathy as well. Psoriatic arthritis is another one. Deep vein thrombosis, so those DVTs can sort of lead to that swelling and discoloration as well. And then obviously your intermittent claudications, ischemia. Ischemia probably less. I mean, generally seeing other changes, but that arterial atherosclerosis as well. So these are probably the main things that can be as that misdiagnosis. And that's, like I said, it's ruling out any of these, particularly obviously your cellulitis and infections, and your DVTs. So if obviously one of those is picked up for diagnosis, then you can probably likely say there's not a Charcot there as well. But then obviously ruling out your Charcots through your imaging will also be, particularly with anyone, and that's where it basically goes down. It says here, the best practice is anyone that has diabetes or a swollen foot, this should be suspected. So if they're presenting with that, and diabetes and neuropathy, yeah, really making sure that we get those diagnoses or X-rays.
And just as I touched on earlier, it's really important to suspect this with an individual with diabetes, because it's about the consequences that gets left behind once the deformities have happened and the fractures and dislocations have occurred. There's really no turning back. And once we get that collapse in that midfoot, it does open up the individual to be more susceptible to ulcerations, which then can lead to infections, which can ultimately lead to that loss of limb.
Yeah, amputations are very common. So, and that's where it comes into that big post-management. If we do get it as a deformity, we are working with that patient ongoing to help offload and keep pressure away from there. So we want to try and reduce that as much as we possibly can.
So probably one of the more key factors of this presentation, where we dive a little bit deeper into treatment. Now, when we are looking at treatment of Charcot Foot, the main aim is to reduce the time to remission and to help prevent the development or worsening of the foot deformities that are already present at first clinical presentation. So as I said, and as I sort of harped on about again, it's very important to pick up on this quite early on, because once the deformities occur, there's no turning back from that. So there are times that even when we're suspecting Charcot and awaiting the imaging, we tend to put people into offloading almost immediately. So an immediate knee-high immobilization offloading, So we get that done as the imaging is coming through, and we'll then, when we get that positive diagnosis, we're ensuring that we're referring straight onto the high-risk foot clinic, so that we can get that multidisciplinary team, such as your vascular surgeons, your orthopedic surgeons, and making sure that there's a whole team of people working, so that we can actually salvage the limb. So anyone can fit up a boot. You can refer off to the podiatrist, as we said, the high-risk foot clinic, and even some physios will fit up a boot as well. Our gold standard is to use a non-removable knee-high device. Now, it's really important that they're non-removable at times, because it comes down to patient compliance. And that's where we see the strongest amount of evidence that if we get someone in a removable offloading, because they're not feeling the discomfort, because they're not feeling the pain, and because they're not even visually seeing the internal damage that's happening to their foot, they tend not to stick to their device and they will take it off. Going on from a non-removable knee high, we'll then look at something like a total contact cast. And then if a total contact cast isn't an option, a removable knee high device should be worn, and worn at all times.
So the big one with that as well is the limitation for obviously a non-removable knee-high device or a total contact cast is ulceration. So if they've had any associated infection, wounds, anything like that, we can't unfortunately put them in a total contact cast. So there are those options where we have to go to that. But yeah, as Jason's saying, you know, when I was at high risk, and we could see the patients almost walk in their boot, you know, wear it to the bus stop, and then sit down, take it off, put their shoe back on, and then get on the bus. And then next week they'd come back and put the moon boot back on to walk back into the hospital. So a lot of these people don't, obviously they've potentially let themselves, you know, and are not aware of the implications and understand it as well as they should, and are going through potentially other things. So it is very important that we know, we'll make them aware and try and keep this as best as we possibly can.
Which I suppose, as part of all our treatments, where the patient education is very important, allowing them to understand the consequences if we don't follow through with this type of treatment.
Yeah. So you want to talk? So these are basically a few options that are those total contact casts in the middle. Over to the left-hand side is a very good moon boot, a vaco cast moon boot. But again, that is removable. But that's a pressure offloading device. And then we've got a crow over here, but I think we talk about those a little bit more on the next slide. Yeah, cool. So these are other things, obviously. So to be as non-weight bearing as possible is the main aim of this. So we want to try and make sure that there is a little to no load going through the foot or lower limb. So using knee scooters, crutches, Charcot restraint walking, or a crow boot, which was that black boot on the previous slide. There's a crutch now called an eye walk, which is actually a sort of straps onto the thigh and knee, and actually works like a sort of another leg. And four-wheel walkers, walking sticks, anything, wheelchairs, mobility scooters, as much load as possible can be removed from that limb is much more, you know, very beneficial to its healing and improvement.
So we do see cases of active Charcot and non-active Charcot. So both can sometimes occur. It's during the non-active, it's during the active Charcot where we want to make sure we intervene quite quickly. So active Charcot presents as a red, warm, swollen foot, usually has those osseous abnormalities on imaging. And we tend, as we said, to see it primarily with people with diabetes, but it's still not limited. A lot of people with neuropathy, particularly chronic alcoholism, is another one that we see it quite commonly with. So during the course of the disease, as long as there's no signs of inflammation in the affected boot, there's no signs of inflammation in the affected foot, the Charcot is presumed to be active. During the non-active, it's in clinical remission. So there's absence of clinical signs and inflammation, with or without the deformity. Temperature differences are reduced, and we use radiographs to look out for those fractures. And if If it's in remission, then it's sort of in its non-active stage of Charcot.
Commonly, so one thing we do see obviously is that repetitive or repeat episodes. So commonly people can go in and out of this Charcot. So, and it can continue to degenerate. So over time they go into it. There can be some resolution, and then obviously they go back to their normal activities and it reoccurs again. And commonly in the contractural limb. So we do quite see commonly people come in that have had an active Charcot in one foot, then the other foot flares up. Now that can also be while they're offloading the current foot. That becomes a challenge because they're trying to redistribute their weight to the other side, which then can cause that Charcot in that foot. But then they also are very common to get a reoccurrence of that activation.
So the next couple of slides probably just gives us a little bit of a breakdown on the types of signs that we'll see in our X-ray imaging or in our imaging in general. On the next slides, on active stages of Charcot and remission stages of Charcot. So we sort of touched on this bit before, but you see that diffuse tissue swelling, you see the joint diffusion, there'll be the cortical erosions, possibly fractures, and subluxation and dislocations will probably be picked up on there. During its more remission stages, we see sort of decreased soft tissue swelling, we see increased bone density, we see the osteosclerosis and the bony consolidation, and disorganizations of the articulations that we do see there. So it's sort of the bones starting to sort of remodel themselves and yeah, form back into a position that will be stable for the individual. So plain radiographs or X-rays, they're actually quite an important tool that we do use when staging this disease. We often see in high-risk department, they'll be sending off for a radiograph probably every 2 to 4 weeks, just to check the progression of the actual disease, just to see if it's further than any of its stages or if the offloading is actually working. And it determines, I guess, how stable the joints would be as well. So, you know, the things that we'll be looking out on is the osteopenia, subluxations, dislocations, and fractures, trying to see if the symptoms are improving or worsening during the course of the treatment. MRI, I mean, this is quite a in-depth sort of slide here, but I suppose MRI would just give us a little bit more information on sort of the soft tissue involvement there. You know, you can see a bit more joint diffusion and tenosynovitis in its active stages. You know, you can also see a little bit more thickening of the posterior tibial nerve as well. So it just gives us a little bit more in-depth investigation as to the damage that has occurred to the soft tissue as well.
Can also with that one as well, in earlier stages, if we're not seeing too many erosions occurring and actual fractures on X-ray, it does show those cortical bone erosions. So that we'll see that bone marrow edema as that, like a stress fracture or a stress reaction, those micro traumas that can occur in the bone. So we will see those on those early sort of stages. So certainly if it's in the very early stages of reaction, then where, you know, plain film X-ray doesn't pick up those stress reactions, this is certainly beneficial on those MRIs. But, you know, again, that's in the very early stages as well. But yeah, we will see those other changes down the track. Cool.
So the X-ray imaging, just some examples of what we'll be looking at. You see in that first image on the left there, you see a nice sort of supported structural midfoot, and then you see that drop in that image below of that midfoot. That second image showing a little bit more of that soft tissue rocker bottom that's occurring in an active Charcot. And then if we have a look at the image all the way on the right there, you can also see that difference between the 2 feet. You've got your left foot that's not affected by the Charcot, and then you have your right foot there that has been heavily affected, and you can see those bony changes and the joint changes that have happened in the midfoot.
it shows up on, again, those MRI changes that we'd see, like we spoke about before. You can see those cortical or bone marrow edema changes through the metatarsals there in that middle image, and then obviously the same thing over on the cuneiforms and the naviculars through that X-rays on the right-hand side there. MRI, sorry, on the right-hand side. So yeah, this is sort of some of the things that you will start to see where we can start to see those cortical changes. Obviously, the midfoot there's not in a great way on that right image, but yeah, we can, some of the things just to pick up on.
So when we're identifying remission in Charcot, so we got our findings of temperature measurements, clinical edema, and the repeated comparison imaging. So as I said earlier, they tend to send off for serial imaging. You have an image taken possibly every 2 to 4 weeks just to compare the changes there. So all of those measurements should be considered when concluding that active Charcot is in remission. So it's also important for us to educate our patients that the transition from active Charcot to remission can take quite a few months. It's not a very fast process, and that's where people do tend to lose their motivation in staying in their offloading. But if we sort of capture them in the very beginning and let them know what they're in for the long haul, it helps them sort of mentally prepare for that as well.
Yeah, because of the destruction of the bones, it does generally take longer than our normal 6 weeks for a nice healthy fracture. So they are looking at generally 2 to 3 months, if not longer. I've had some patients up to 6 months in moon boots. So it is a slow process.
So although we don't just rely on temperature measurements, the higher the temperature measurement between the affected and unaffected foot, the greater the likelihood of ongoing disease activity is happening. The lower the temperatures, the greater the likelihood that Charcot is going into remission. It is really important to note, though, that there's actually no gold standard for ascertaining remission or for finding out if Charcot is in remission, which is why we have to use our clinical judgment and the comparison to imaging to ensure that this disease is in remission. So surgery or no surgery, the evidence around it is quite poor for surgery. It's usually, as we said, people being offloading, which is probably the most important thing. Believe post remission, sometimes surgery may happen if the deformities and destruction is quite bad, but that's where the referrals into the high risk team is quite important, because they'll be working with a team of orthopedic surgeons to ensure whether or not something like surgery should be considered. But you also have to take into consideration the patient's age, their overall medical conditions, and coexistent cardiovascular or renal disease. When we see people with quite advanced diabetes, we can see sort of that higher risk of cardiovascular disease and renal disease, and they just might not be perfect candidates for something like surgery.
The other side of things was their compliance to go with their current care as well. So if their compliance was very low with the management of their active Charcot, then a lot of the time surgical intervention will sort of reactivate that. So if they don't have a good compliance with that, they're not likely to comply post-surgical as well. So they certainly take all these factors into understanding and looking at it when they're looking at that. But there is a place for surgical intervention, particularly with those people who have done it but still have had a pretty bad reaction. Also, the other thing, I lost Downs.
Sorry.
One sec. Oh, there it is. Comes back. There we are. So yeah, and so also the bone degeneration. So we do see a lot of osteopenia. We see a lot of sclerotic changes in the bone, which obviously aren't very good for surgical sort of return as well. So it makes it a lot harder for them.
Just like all surgeries, it comes down to a risk-benefit ratio. If the risks are going to outweigh the benefits, there's probably no indication for surgery. But if we do see that heavy destruction, which will lead to possible further ulcerations or mobility issues, then sometimes surgical interventions can be indicated there.
Yeah, I mean, just for example, I had a patient recently who's had an active Charcot. She's now in remission and things are going really well, but she had a really large osteophyte on the dorsal of her ankle joint. And so it was actually limiting her ankle range of motion quite severely. So yeah, the orthopedic team came and removed that, and she's had really good, recovery from that and gone really well with that outcome. But again, they didn't do anything too structural. It was just that osteophytic lipping that was jamming her ankle joint, and that's been really successful. She healed really well.
So pharmacology and Charcot. So there's no evidence to support the use of any other pharmaceutical intervention. So yeah, there's down below. There's actually it's actually recommended that we don't use any biphosphonates, calcitrin, parathyroid hormones, or denosumab in the treatment of Charcot. There is some evidence to suggest that vitamin D and calcium supplementation during the treatment of active Charcot can be there to sort of treat the hypocalcemia.
Increase that, yeah. Osteoporosis, reduce that osteoporosis and increase that bone density.
So who can actually help a patient with Charcot? So a prosthetist,
an orthotist, or a podiatrist for basically custom-made footwear, custom-made orthotics. So that's really where our sort of management comes in post, particularly if we do have those known deformities of the foot. So we'll look at specialty footwear, offloading devices, custom orthotics. So there's custom orthotics. People think that they're very hard and very rigid. In this case, we make a device called an accommodative orthotic. So it's actually basically accommodating the deformity rather than trying to change pressure. Obviously, with a person who has had an active Charcot prior, you don't want to increase pressure in a certain area. So we're actually looking to basically bring the ground up to the foot and even that pressure distribution through the foot. So these devices are made of very soft materials and are very accommodating. Generally, we have to make modifications to the shoes or customize shoes to accommodate these deformities. So yeah, these are your sort of go-to options. These are something we make quite regularly in our clinics for people who do have these deformities, and can certainly help.
But yeah, so we're trying to prevent the reactivation of the disease. And just as written down below there, despite the lack of evidence, the IWGDF still does recommend that therapeutic footwear would produce benefits in terms of reducing the reactivation of Charcot foot. And it's all just coming down to redistributing weight and managing the stress on those joints.
Even there's evidence around even using a simple running shoe from Kmart will redistribute pressures quite well and reduce them, rather than those rocker bottoms or that sort of toe rocker can really reduce those pressures even in that sort of footwear. So getting them, potentially changing the footwear for the patient can make a huge thing. Obviously, costs sometimes can come down to a big thing. Some orthopedic shoes that we recommend are $400 or $500. So that can be really limiting for a lot of patients. There are schemes, obviously, if they are on pensions and things like that, that they can get subsidies from the government, ACT government. And so that's another thing to explore for those patients. But yeah, there are benefits in simple footwear changes can make a huge difference to those pressures and those plantar pressures.
There is also the use of custom-made footwear. I do have a patient myself who has quite a severe case of Charcot, and the destruction was quite severe. She is in custom-made footwear, which would have been made by the prosthetists.
Yeah, prosthetists and orthotists.
Yep. However, even just a bit of a insight into that. Yeah, orthos. Sorry. Even a bit of an insight into that. These shoes are probably a couple of $1,000.
Yeah.
She doesn't wear them.
Right.
Yeah. So again, it's coming down to that education, and it came down to sort of trying to find that even level where We just had to get her in a normal shoe with normal supports and normal orthotics because she doesn't want to be walking about with these huge custom-made shoe. So it's just trying to find the right treatment for the right person as well.
Definitely.
So a lot of our resources today, if we dive deeper into the IWGDF guidelines for Charcot, they were written in 2023. They haven't been updated yet. I checked that the other day. They haven't been updated yet, but if you do dive deep into that, you can find a whole list of recommendations on treatment, prevention, or not preventions, but treatment and management, and also picking up on the actual disease itself.
Diagnosis.
Yeah, diagnosis.
So yeah.
And I think we're just, if we have any questions.
Yeah, awesome. So we might throw back to Sheila there and we can field anything we might have.
Thank you very much, Ricky and Jason, for such an insightful presentation. You made a complex topic so much easier to understand. And now, so we'll go over to our question and answer portion, and let's see if we have questions. I might have to ask you both to stop sharing the slides for a while, if that's all right. Sorry. Thank you.
Great.
We'll just have to. All right. So I've got one question that's come in here. Sorry. So do you have to wear a crow or offloader your whole life? So for the patient, that is.
So, sorry. So basically, no. So what happens is once we are in that reactive state, and we can get it back to that non-active state, and the joints have healed and are in their new position, then no, we can basically go to remove that device and then go to either footwear or other modifications that we might do. There is obviously that risk that they may go to that back into that active stage, but no, but they will be able to remove from that crow or offloading device and modify that. Like I said, they may be in that for 3 to 6 months, and then we will be modifying them into other devices.
Thank you. One of our GPs has also sent in another question. If caught early or in the active phase, can Charcot's foot be reversed? And if not, how much of the progression is prevented?
So no, unfortunately, that's one of the things with Charcot. It cannot be reversed, which is why early detection is quite important. So whenever we have that first clinical sign of Charcot, as we said, whether it's someone with diabetes or neuropathy, and we are seeing that red swollen foot, we want to send off as soon as we can for radiographs to rule it out, because if it is Charcot, we want to offload as soon as possible. The sooner we offload, the better it is, the better the outcome is going to be. So we can't prevent it, but we can try stop it in its tracks before the destruction settles in.
So effectively what that is what it's a microfracture or a fracture. So that we can't ever go back from having a fracture. It's just how that fracture is managed and if it becomes displaced or not. So exactly as Jason said, no, we can't make it, it will heal, but it's just how much it progresses in that time is the main big thing. So really, early intervention, the earlier we can get it, the better. It's going to prevent that progression.
Okay, thank you. Let me just read this next one. Are there patient-friendly resources that you can recommend? Or maybe this is referring to websites or...
Yeah, we probably don't. We might ask, certainly, so we work with the ACT Health and sort of things. If they have any resources they can sort of give out to patients around that. We don't currently have any that we sort of have personally. We could certainly get something together for people. I guess
probably the more important thing in terms of patient resources, particularly if it is a patient with diabetes, just encouraging them to have their yearly checkups with a podiatrist, so that we can ensure that there's no signs of neuropathy. We can ensure that that the disease or the diabetes isn't progressing into something like neuropathy, because the thing that we would hope for is that a person doesn't progress to the point where they do have Charcot. So if we really get the prevention in the very early stages by ensuring that their diabetes is well managed and their foot care is well managed, we would hope that no patient has to rely on the resource if they do have Charcot, but we can definitely look into some resources there.
Yeah, so big those things are prevention. So foot health and related to diabetes as much as we possibly can. So yeah, relay that. But yeah, if anyone does, we're happy to, obviously, Sheila, you can pass on my email. If anyone wants to get some more information about it, we're more than happy to, and we can again combine that with ACT Health and stuff. But you're right, the biggest thing is education of those patients and what they don't get it. As Jason and I touched on before, they don't understand because they can't feel it. You know, if you're walking around, you or I are walking around on a broken bone, it hurts. You know about it. You don't want to walk on that foot. Unfortunately, because that neurological status is not there, they don't know, and it does really cause that breakdown. So, and education is the biggest thing.
Yep, thank you. And the last one that we've got here. So, which normal footwear brands would you recommend for the plantar pressures?
Yeah, so there's a lot of sort of different, evidence around what sort of shoes make a difference, but there's basic attributes that we look at, which is a toe rocker, a cushioned midsole of the shoe. There's no specific brand that you need to get because every brand will fit very differently. But certainly there's some research that we can share around a very flat, thin shoe versus a very cheap, I think $20 or $30 shoe from Kmart, really, and redistributed those pressures very significantly. So as I said, we don't need to get anything amazing, but I think Jason's got an example here to sort of pop up in front of the camera.
And we're just talking sort of that, what we sort of mean with that toe rocker. It's quite stiff sort of through that forefoot there, and when the person's walking, you actually get quite a bit more movement through the actual shoe instead of putting that pressure through the joints there. Basic attributes, we're looking for sort of stability. We're still looking for that. We're looking for that rigidity in that midsole there. So it does vary from patient to patient, but I know I often look at Brooks or Asics as just general sort of brands, which can be great for sort of pressure distribution as well.
A lot of the brands have changed their shoes recently, going to these much higher stacked, higher cushion shoes. So we've got lots of distribution of pressure through this midsole, and using a lot softer sort of foams. Go the other way. Which really redistribute those pressures really well. So this sort of shoe combined with an offloading orthotic, it really works very well. It just comes down to if they really have that medial deviated sort of deformity, then that's where we need to look at more customization, and we might actually get a shoe like this built out into that area. So again, as Jason was saying with his current patient who's got those custom made footwear, we don't always need to look at that. We can look at modifying current footwear to give those attributes, and that's something else that can be looked at. So there's lots of modifications that can be made there.
Very important points. Thank you very much. That's extremely helpful. Now, before we wrap up, I would also like to mention that Diabetes Australia has many resources and e-learning modules for healthcare professionals. So I can just get that out of the way. For health professionals who are caring for people with diabetes-related foot disease. So if you are interested, please visit their website, footforward.org.au. You can register for the training modules or download resources, including an integrated diabetes foot care pathway. And I think those pathways also give the recommendations of when to see a podiatrist and the schedules. And evaluation surveys for tonight's presentations will be sent out shortly. So please fill in the post-event evaluation survey so that CHN can email you a certificate of attendance after the event. Please feel free to self-report. I know we're finishing a little bit earlier than usual, but it is usually up to 1.5 hours of educational activities to your CPD home. Now, resources, presentation slides, and YouTube recordings will be sent by email to participants who complete their evaluations. And please do visit the CHN events page for details on upcoming clinical education. This is also usually promoted in our newsletters and social media pages. And once again, thank you very, very much for coming tonight, and thank you so much, Ricky and Jason, and to the Walking Clinic for your excellent presentation. And we hope to have you back, discussing other topics.
Yeah, thank you everyone for attending as well, and we really appreciate it. And thank you, Sheila, for spending your night here. And wanted to say, obviously, if anyone does want any more information or we can assist in any further way, don't hesitate to reach out. Obviously, Sheila, you can email Sheila and she can pass on my email address. Jason and I are happy to answer any questions or help where we can. Or if there's just general information anyone wants on podiatry or anything like that, we're happy to assist as well. So please let us know.
Sure, thank you, and everyone enjoy the rest of your evening, and we'll see you again.
Thank you very much.
Good night. Thank you. Bye.